Zimmer came up with a kind of a new way to do total knee replacement. It is called patient-specific instruments. And basically, we take a MRI of your knee prior to total joint replacement. We make blocks of your knee, and then from that we manufacture patient-specific instruments just for your knee, and we think we get a more accurate total knee replacement, which I will show you. The biggest symptom of osteoarthritis, of course, is pain. The pain can be at rest, it can be with movement, it can be with bent knee activities, it can be with a lot of activities. When the pain starts interfering with activities of daily living, that's when we have to start doing some things to try to alleviate some of this pain. Arthritis brings about excessive wear. Oftentimes you develop arthritis from sports injuries. The number one thing that causes arthritis, of course, is age, and a significant number of patients over age 60 will have some arthritis, especially radiographically. The deformities can be either knock-kneed or bow-legged, all of that from the osteoarthritic process. There are 4 bones in the knee: the femur, the tibia, the patella, and the fibula. But what we're concerned about with osteoarthritis is the joint surface, is the patellofemoral joint and the femoral tibial joint. There are static stabilizers of the knee, which we've all heard, especially when we're talking about NFL players and basketball. We're in the NBA finals now. And the ligaments, which are static stabilizers, they don't move, keep the knee stable, as well as muscles about the knee. The front patella tracks in the femur, and that's especially comes into play with in and out of the car, up and down stairs, etc. The knee is a hinge joint. There's 2 big ligaments on the inside, the posterior cruciate, and of course, we've all heard about the anterior cruciate, which is injured often in cutting sports. There's also 2 cushions in the knee, which are the menisci, the cartilages that are often torn in sporting activity. With age, those can also be damaged. What happens initially is you may not even have any radiographic changes. This is what's called a front-on view of the knee. And you can see very little signs. Just like I said, a lot of people over 60, up to 1/3, will have some radiographic changes. One of the first things that happens is the smooth surface over the knee, the hyaline cartilage wears out or gets destroyed. And that cartilage loses its ability to cushion the joint, and that's called joint space narrowing. Can everybody see how the lateral joint, you have a nice joint space here, and you see how that's narrowed right there? One of the first signs of osteoarthritis, and of course, that's painful. When the disease progresses, usually with time and age, you then have joint space narrowing all the way, which you can see here on the radiograph on the right. And the cartilage breaks down, and then you have what's called bone on bone. Bone on bone is what gives that noise that people talk about. Oh, my knee creaks when I go up and down stairs, when I get out of chair. That's called crepitance, and that's from the joint space narrowing. And then finally, the body's ability to try to immobilize the joint a little bit, the body will actually develop what are called bone spurs or osteophytes. And you can see the severe joint space narrowing on this x-ray. I just want to make the big point that every guy will try to treat, every treating physician will try to treat you conservatively for as long as you can, but then a time is going to come where you're going to come in and say, Ray, I've had it, I want fixed, you know, something has to be done. Well, for the next few minutes here, we're going to talk about, you know, total knees, kind of how we do them, and kind of talk about this new way that we've been doing about the last, 5 or 7 years. A total knee replacement is a very good surgical solution. The good or excellent results are approximately 94 to 95%. To achieve that good or excellent result, it's based on 2 factors. Of course, one is the surgery itself, which is what we do. But that's only 50%. That is only 50%. Total hip replacement, a little bit higher than that. The surgical experience for a total hip replacement to get a good or excellent result, about 90% based on your surgeon. But in a total knee replacement, it's 50% the patient, 50% the surgery. The therapy is just as important, which of course the patient has to have, and I think we're really pretty good with our hospital here for getting folks into therapy appropriately. Well, basically, what do? Well, we excise off the diseased bone, we get it down to smooth bone, we replace the femur with some metal, we have an insert made of ultra-high density polyethylene, and then the tibial component is made out of titanium. Most of the knees, you almost can't even tell the difference. We've kind of figured out what works pretty well. There was a symposium that I was recently at our academy, which is the American Academy of Orthopaedic Surgeons, which both Dr. Shannon and I are active members. The Socratic debate was, can you tell your patients that I'm going to put a knee in you that lasts 20 to 25 years? And it was interesting because both of the presenters kind of agreed that you can't say that. Usually it's not, if something bad happens, usually it's not based on the wear of the components, but the components do work pretty well, 20, 25 years, sometimes 30 years. So just like what we showed in the previous slide, we remove the damaged parts and we replace the damaged parts with the total knee replacement. There is a lot of research going on as to what's the best way to fix it to bone, etc. Total knee replacement works very well with cement, and most guys still cement the femoral component, the tibial component, and the patellar component. And that's exactly what it looks like right there, and with the use of the bone cement. The same thing with the tibia. You just excise off, you get down to good bleeding bone, and then you put the tibial component, and then this insert right here is of various thicknesses depending on the stability of your knee. Everybody is a little bit different, and what ligaments are lax, what ligaments are a little bit tight, and try to get what's called a well-balanced knee. How long will the implant last? If you say 15 years, you're really in pretty good company. Usually I say 20 or 25. I had a patient just in the office last week that this was her 22nd year. I had a patient in the office this morning. I did her one 03 and I did her other knee 05. So how many years that is? 19 and 16, something like that. The longevity, of course, a lot depends on the man holding the knife, the woman holding the knife, but you really got to correct the surgical alignment. And then, of course, you have to fight infection. What I say to folks is, if you treat this knee well, it will treat you well. You know, we're not going to turn you into, basketball players or anything like that. You know, you can't play paddle tennis and you can't play golf and you can ride a bike and you can walk, but we really don't want you playing, pounding sports, which are going to bring about early wear on the knee. You're in the office, you come in, you see us, you say, Ray, I just can't take this anymore. I want one of those magic knees, blah, blah, blah. And I keep hearing about this patient-specific instruments. Well, what do I have to do? What do we do? Well, after you're a candidate for surgery and you're cleared for surgery, your cardiologist, your internist said that everything's good, we are going to put in a component that matches your anatomy as best as possible. We are going to make some jigs that fit your knee almost like a glove. Now here is one of our patients, and here is her patient-specific instrument, patient-matched instrument, and you can see how it just fits on that very, very snugly. I can tell you that it actually is better, it's better with in actual live patients, in what we call in vivo in the operating room. So this gives us just a little bit better alignment, maybe a little bit quicker, hard to say, it's depending, but how we get there is that we take an MRI of your knee. From that MRI, we 3D print your knee. So here's your 3D print. From the 3D print, we manufacture the patient-specific instrument. During surgery, we mount the patient-specific instrument right on the femur, right on the tibia, and it helps us achieve exact cuts and a little bit more accuracy, a little bit more precision. Now, is this the robot? No, it's not the robot, but we do use the computer to achieve the patient-specific instrumentation. And then, of course, when we're done, this is what we want to achieve, is a well-functioning, pain-free knee. And that's exactly what it looks like right here. I can't emphasize enough how important the post-operative care is. The surgery, just like what I said, is only 50% of the solution. The other 50% is the physical therapy. Just to let you know how things have changed, when I started practicing here 30-odd years ago, I would pat myself on the back if I got my patients out of the hospital at 6 days. Then Medicare cut us down to 4 days. Well, that was okay. And then for quite a long time, it was 3 days. Guess what it is now? 1 day, maybe 2. Now, gray-haired guys like myself, we were all up in arms about that. We were really worried about, that, but it's actually been shown that the complication rate is less when you get patients home, out of the hospital, with home physical therapy, home nursing, and they actually do better. I just wanted to talk just a couple of minutes on some new things that we're doing. Wanted to show you the instrumentation, and I think I have maybe 2 minutes for questions. Are there any questions for me?
Good evening, everybody. Can everybody hear me in the back okay? Like I said, it's a pleasure to be here tonight and kind of give you some insights on some of the things that we're doing at Southwoods and everything. And my talk tonight will be about the anterior approach to total hip. As Steve alluded to, I did my undergrad at the University of Notre Dame, and one of my professors always wanted to have class on Saturday, so here I am trying to listen to my teacher here at the time. But a great kind of a legend in this area, and a great guy to spend 4 years learning from there. So what is hip arthritis? And Dr. Duffett did a great job kind of giving you some of those, the basics of arthritis, particularly of the knee. But what happens in the knee? Cartilage on both sides of the joint. And that stuff is a lubricated, very low friction surface, and everything moves easily. There's little pain. You don't think about bending, standing, climbing stairs, climbing ladders. And over time, with wear and tear and maybe an injury or two, you start seeing thinning of the articular cartilage, that smooth surface on the end of your bones. And as that cartilage thins, you start getting a little bit of what we call micro instability. The body responds to that by trying to stabilize your joint, and that's why those bone spurs form. And you also get kind of the counteract to the raised bone spurs. You get these little divots called subchondral cysts, and that really changes that smooth joint surface to something very much akin to sandpaper. So now you have two kind of rough surfaces wearing over top of themselves, and that pain creates some disability and leads to some muscle weakness. And you finally get a joint that kind of has these rough irregularities with kind of a stiff capsule around it. Everything. So what are the risks for arthritis, primarily of the hip? Age over 60 is where we start seeing a lot of changes in the normal joint of people who haven't either had rheumatoid arthritis or different traumatic events. Gender, women tend to have more symptomatic arthritis than men. Particularly men younger than 50 tend to have more osteoarthritis requiring treatment than women, but when you get above 50 into the 60s, women tend to show more arthritic changes and have more arthritic symptoms. Obesity is a big player for both hip and knee arthritis. The hip, for example, sees about 6 times body weight in single leg stance. So that's why you'll hear either your orthopaed or your family doctor saying, weight loss can be very helpful in helping you preserve your joints and being able to have less symptoms. Because a 10-pound weight loss, your hip sees 60 pounds less weight. And that makes a big difference with how many cycles or how many repetitions we take steps and run, jog, etc. Genetics, there are some people that are born, their hip just isn't round. And it's kind of like having an egg inside of a regular cylinder. And if they don't match up well, they tend to wear out more quickly. And we do see that. And then again, that's more common in females. Occupations, people with high lifting demand, labor jobs tend to have a little more arthritis. And then athletes that play collision sports, high impact sports, also tend to get arthritis earlier than some people that play other sports or have other occupations where there's more sitting involved. And then direct trauma, auto accidents, falls off a ladder, falls down stairs, all those things kind of contribute to early injuries, and that micro trauma tends to lead to that cartilage thinning and the bone spur formation, which creates the pain that we all dislike. So what are the symptoms of hip arthritis? People complain of pain with walking, pain with standing. They usually talk about it in their groin or their buttocks area. They have difficulty walking long distances. They have difficulty standing for long periods of time because of that. And they get stiffness. The first dozen steps out of bed are generally uncomfortable, causing them to limp, maybe use a cane when they get out of bed in the middle of the night to go to the restroom, things like that. Sitting, go watch a movie or sit down and watch television for an hour or so, that those first dozen steps up from the seated position are also, they create a fair amount of pain. And then when they step on it, all of a sudden it's just not there to hold them or support them. They'll feel like they might fall as the hip gives way. What are the physical findings? When I see somebody in the office, I always want to do a good history of what the problem is, listen to the patient, tell us the story, because that's where most of our clues are coming from. A good story, giving a chance to listen to people talk. That's how you find out a lot about people's problems. But on exam, check their leg length. You're often short, slightly short on the arthritic side, and people will complain, I just feel like my leg's not as long as my other leg. They have an antalgic gait, which is a painful gait, limping when they get up. They tend to walk with a long and then a short step as they move, taking one step at a time up and down stairs is a very common thing to see. And then they have loss of range of motion. The two stories that you'll hear, classic hip arthritis stories, are I have trouble putting on my shoes and socks on that leg, and when I get in the car, I have to lift my leg into the car. So those are the classic things that we see on physical exam that correlates with the story we hear. Now, X-ray findings. Again, Dr. Duffett did a nice job of describing some of those things. The first thing we see is joint space loss. Again, you can see the normal joint. We see a nice spherical, nice round femoral head here. Then the socket here. And that space in between is not air, that's filled with cartilage. Cartilage just doesn't have any metallic object, and it doesn't reflect back on X-ray. So that's where the good cartilage is living. And when we come over to the arthritic joint, again, we see this complete joint space loss. You have this spur here, you have a spur down here, and you have these indented dark spots called subchondral cysts. And again, you see flattening of the femoral head. And the other thing you'll see in arthritis of the hip, you see what we call a sourceal, which is increased stress along the upper part of the acetabulum or the socket right here. And these things very painful. And you can see why that would make your hip feel very painful and very stiff if you tried to move it with all those spurs and just the change in the anatomy there. So how do we treat hip arthritis? Again, as Dr. Duffert alluded to, a good doctor is going to try and give you a treatment regimen that encompasses both non-surgical things and surgical things. The first thing we want to do is try and get someone to kind of exercise, because exercise is important to build strength of those muscles. But again, light exercises, things like swimming, aquatic therapy, which is kind of vertical exercises in a pool. Yoga, stationary biking is excellent. It's widely available both at home and in any of the gyms you may belong to and everything. And then sometimes we'll send people to physical therapy to strengthen those specific muscles around the hip abductors and the glutes that kind of help stabilize the joint. And they need specific exercises to strengthen them, and also work on keeping and maximizing your range of motion so you can use those muscles over that full range of motion coming from a seated position to standing, etc. Again, weight reduction is critical to the longevity of joints, particularly when you start seeing the initial signs of arthritis. Again, the hip sees about 6 times body weight in single leg stance. Heat and ice can be there for kind of local comfort, particularly after you've walked some distances or had a busy day. Icing it, I usually tell people a family-sized pack of frozen peas for 20 minutes. You can do it, throw it back in the freezer. Just remember not to serve it to your family there and everything. And then assisted devices. I mean, these are amazing because, one, they're inexpensive, they're readily available, and they work. A cane, a walking stick, a walker, all are amazingly helpful in letting people continue to do their activities of daily living. Because what hip arthritis does, and what many of the orthopedic problems that we address, they tend to cause a decrease in your quality of life. And part of that is it takes your world that used to be this big and it makes it this big. And then as the pain gets worse, it gets this big. And then all of a sudden you're going from your living room to your kitchen and things when you'd like to be out at restaurants or out visiting your children or grandchildren. And this pain can cause you to lose that. But an assisted device, again, a cane, a walker, a walking stick, lets you go further with less pain and you look more natural in your gait while you're doing it. So very important tools. When those things don't work, and we often couple all these treatments with some type of medication. Certainly Tylenol is generally a very safe and a very good medicine to start with. Most people tolerate it well. It has very few side effects. Doesn't mean it's side effect free, but Tylenol is a good choice. Then the medications we probably use the most of are non-steroidal anti-inflammatory medications. Those would be medicines like Advil, Aleve, Mobix, Celebrex, naproxen. Those would be the medicines you can get over the counter. You can get them at a grocery store, a gas station. And they are very good at controlling inflammation, which is a very early and probably the most prominent portion of the pain response in early arthritis is the inflammation. So if we can control the pain with anti-inflammatories, it's a good way to go. Some of the downsides to non-steroidals, if you read the back of the box, and any of those over-the-counter meds you get or any of the prescriptions we might write for you, they all have a black box warning for myocardial infarction and stroke. It's important to know that. We all take them and we use them, broadly, but you'll hear your family doctor tell you, you shouldn't take non-steroidal anti-inflammatories either because you have a heart condition or you have a kidney problem or you have stomach ulcers. Those would be the three things that we commonly see for other people's general medical problems that limit our use of non-steroidal anti-inflammatories. Glucosamine and chondroitin is more kind of a natural remedy, and it does give people some relief in their early phases of arthritis. And then cortisone injections, which is injection under an X-ray machine where we put cortisone, which is a very potent anti-inflammatory, into the joint, and it quiets down the inflammation in that synovial lining. All our joints, diarthroidal joints, are lined with an inflammatory synovial tissue. And if we can control that component of pain, people tend to function well. Those anti-inflammatories do not work well when bone is exposed against bone and nerve endings in the bones are being irritated because it's not an inflammatory pain response. And then when those things stop working well and your quality of life really drops below where it's acceptable, we talk about hip replacement. Hip replacement's really been around since the early to mid 60s. If you look at Sir John Charnley's work in England, which is really where hip arthroplasty they really worked out the details with this in the 60s. But it's been a very successful operation to treat the problem of hip arthritis. Hip replacements give profound pain relief. They improve range of motion, and most importantly, they improve patients' quality of life, so you can do different things. Okay. So what is the anterior approach? We're here to talk about some of the newer techniques in hip replacement. The anterior approach really allows the surgeon to approach the hip joint from the front with the patient laying directly on their back. And it lets you kind of replace the hip, importantly, without having to cut or detach any muscle tissue whatsoever. We work through an inner nervous plane, which Dr. Duffett understands that part. We work with the femoral nerve is the nerve that feeds kind of the inside of the leg, and that feeds the sartorius and the rectus. And then on the outside, the tensor fascia, which is kind of this muscular band that goes down the side of your leg here. And I'll show you that with some anatomy here next. With the gluteus medius, which is one of those important hip moving muscles, is fed by the superior gluteal nerve. So we work in between these muscles that have different innervations, and we don't have to cut them or detach them to actually get to the hip joint itself. And here's what that anatomy again looks like that I alluded to there. But here's where that incision is made. It's a 4-inch incision right here. We split the fascia, but do not touch this muscle, and we work in here. This is the sartorius, which for, if anybody cares, is Latin for tailor. And if you ever see anybody talk about being dressed in sartorial splendor, that is what tailors used to use to hold their knee up to do their stitching and things. But anyway, the interval we work through here is right here, and it's a 4-inch incision to enter the hip. Oh, maybe it is working. Okay. So what's the difference between, minimally invasive surgery and the anterior approach? There's a lot of talk and there's a lot of different ways that we can approach the hip through a minimally invasive way to put a hip replacement in. And really the question is having a smaller incision on the outside more important than what we do on the inside? And the nice thing about the anterior approach, while this incision is about 4 inches long, when we get beneath the skin, fundamentally we have a different approach in that we make no cuts in muscle, we don't detach muscle, and that leaves these muscles in their normal function post-operatively, and you can stand and sit on a toilet seat and sleep on your side, the night of surgery if you want. My anterior hip experience, I learned how to do this and did my first hip replacement in 2005. I've done more than 2,000 of these anterior approach total hips. I'm thankful to be able to have been doing it at Southwoods for the last 5 years. Southwoods, again, has the newest and best equipment available. A very experienced surgical staff. The nurses and scrubs that surround me in the room have a wealth of experience. And post-operatively, they have a well-experienced and knowledgeable physical therapist. Again, as Dr. Duffett stated about the post-op rehab is important. This is an example of a hip incision. Again, it's 4 inches long, closed. This is the table that we use to put people on. Again, when we would bring you into the room, you'd get some anesthetic, so you won't remember much of this. But this is the table, or any of it. You won't remember any of this. You'll remember kissing your loved one as you drift your way into the OR. That's what most people remember, which is what we want. But this is what the table that we start on. And this table allows us to do work through that 4-inch incision. So this is the position you would start on. And this is also the position where I would put in the socket part of the hip replacement. And the nice thing about this is you can do it very precisely through a very small incision. The X-ray guides the shaping device called a reamer. And you can see it on X-ray. You can see how deep you are. You can see how accommodating you are to the size of the socket, so you can be very accurate. And then when you're placing the implant, it's important that this implant is placed correctly to help prevent dislocations, help prevent any stiffness post-operatively, and you can watch this implant over here be placed into this position right here. So it allows for very accurate placement. This is a position for placing the thigh bone implant, the femoral component. And again, the table lets you drop the leg, rotate it out to the side, and that brings that piece of bone right into view so you can easily place the stem down the middle of the bone. Post-op protocol, some of the nice things about this, there are really no dislocation precautions in that patients' activities of daily living are all done generally with the hips apart, the hips flexed. You're reaching forward, you're going to the restroom, you're getting up from a chair, and all those muscles are left intact and are very actively working to keep your hip in the socket. There's no post-op activity restriction. And I guess I would preface that to say, I really don't want people on a ladder for about 6 to 8 weeks. I also tell people who are avid golfers, they can play golf, they can chip and putt. I don't really want someone driving off the tee or for about 6 weeks as we let these ingrowing implants grow into the bone. So, but for 90% of anybody's daily activity, there are no restrictions, and you can be full weight bearing. You can sit on a standard toilet seat immediately. There's no toilet risers. There's no real concern that someone might dislocate as they sit down or come off the toilet. And you can cross your legs, the night of surgery if you want, because that position is a very safe position, given that the muscle sleeve and things are left in their anatomic positions. The key benefits, again, in way of review, we have an accelerated physical therapy protocol because all the muscles around the hip are left intact. Rapid return to your activities of daily living. Sit on a normal toilet seat. You can sleep on your back. You can sleep on your side without any concern. Return to earlier driving. I usually tell people that you're going to be on a walker for about 7 days, and when you transition to a cane, you can start driving again. Although I also would allude that if you're taking narcotics, that's a felony. So we want to make sure you don't take a Percocet and then drive. Again, you have immediate stability of the hip. There's no muscle cutting, therefore you have reduced tissue trauma. Reduced dislocation risk, although there is a risk for dislocation. You slip and fall on the ice, you fall down a flight of stairs, a lot of things can happen. There's a lot of energy involved with we call mechanical falls. And another nice thing is in that supine or laying directly on your back, it's much easier to control leg length, and you can prevent from needing a heel lift or a shoe lift because you can more accurately recreate the length of the other leg by balancing them radiographically in the operating room. The procedures, first time or primary total hips can be done. Certain revisions, I've probably removed the socket in, probably 50 or 60 people through this approach. So you can do some revision surgery. Hip fractures, broken hips can also be done very well through this approach. Thank you very much for this time and this opportunity.